Hello everybody, welcome back. This is Dr. Mark, a DuPéré plastic surgeon, Visage Clinic here in Toronto, Canada. I want to say thank you to this young lady for agreeing to this filming. I thought today it was an interesting case to discuss because we are doing exchange of saline implant with new saline implant after one rupture and a mastopexy. So when I met this lady, she's had breast augmentation long time ago, saline implant. I did have access to the number of ml she had and the type of implant. They were smooth, but saline implant. And this one was bigger, was smaller than this one. So this one had a larger volume of saline compared to this one. But when I met her 6-7 weeks ago, this implant was completely collapsed. Now, people need to know when saline implants rupture, it's like a tire that gets flat on the road, you see immediately the flatness. Whereas a silicone implant, when it ruptures, it's super rare, but when it ruptures, it stays within the capsule that the patient has made post-surgery. A capsule is a bag of collagen that the body forms against a foreign material. And in a silicone rupture, the silicone stays around the implant, but within the capsule. So it's not always obvious there is a rupture. And often we realize there might be a rupture when patients do their routine ultrasound mammogram. Now, saline implant ruptured here. She came to see me. This side was still pretty good. The nipple areolar complex had sagged down, so she needed some sort of a smaller lift for this areolar tissue. So I proposed to her the so-called donut mastopexy, or the Benelli periareolar, where we remove a larger amount of skin around the areola. We move the areola and we close the bigger circle around the areola, shifting it up. There are limitations to this, how much we can lift, but this was perfect for her. Now this one I did not know. She was completely deflated. There was some indentation at the scar from before. So I told her my plan would be to do this one on the table and to try to match this one to this one. So once this was done, we opened this one. I found the old implant, removed it. Look at the capsule, which was still relatively good. Again, I had to open up here on each side to accommodate a larger implant. We put our two sizers in there, sat her up, and then did the modification as needed internally. And then I planned again the mastopexy. Fortunately, this breast, once the new implant was in, looked pretty much like this one before. So I was able to reproduce the donut or the Benelli mastopexy on this side. Now, as I said earlier, she had an asymmetry at the original breast augmentation procedure. I did have the paperwork, which was very helpful, but it doesn't allow me for some asymmetrical volume with silicone implants. So she chose saline implant, which allows us to change volume to some extent. We have a range of volume we can put in a saline implant that does not happen with silicone implants. Silicone implant, they come already made and filled. So I will show you how we do this because we don't often do saline implant. This is a sizer. The real ones are more transparent, but it's the same idea. They come empty. We remove the air. Then we start putting a little bit of fluid in it, saline water. We roll it like a little cigar. We put it into the breast, and then we continue to augment. And it's obviously important to measure. So this is a one-way valve system. She's got about 200 already in because I did another video a few minutes ago. And now we're just pushing. It's a one-way valve, and you can see that it's inflating. And basically it allows us to control the amount of cc's we're putting in. And for her, it was very useful because she had an asymmetry where the left side was slightly smaller, something I could not appreciate initially because this was deflated. Now, advantages of saline implant, again, it's water-filled, it's the safest you can have, it's a little bit more economical for patients. But the big deal is that I can adjust volume. The disadvantage is some people feel they don't feel as natural. If the patient is very thin, sometimes those saline implants have ripples here. She has a bit of soft tissue coverage. I'm not concerned for her. Plus, she's got a very nice capsule that will cover all this. And we're going under the muscle. This is where she was before. We stayed submuscularly, and there's a lot of coverage for this. The other advantage is if it ruptures, it's an easy fix. It's also safe because it's water, which she will pee out later in the day. Now, most patients choose silicone, 99% of my patients, because they feel slightly more natural. Anyhow, I thought this was an interesting case to show you, and I will show you our final results. This one was 600 cc, so she wanted to go about 100 more than before, and this one 665 in order to match the volume. Again, this one was a bit smaller, and we made something very nice with a nice cleavage, nice no lateral displacement, and the peri-areolar incision. It's a bit whitish around because of the adrenaline we use, because it's a bigger circle to a smaller circle. They get little folds that within a few weeks will be gone. So I want to thank my patient again for agreeing to this filming. I hope you found it interesting. Have a good day.